Today we did our first peritoneal dialysis. The multidisciplinary team encompassed a lot of people. So we had the pediatric anesthesiologist, we had the theatre team, the pediatric surgeons, and then we had the pediatrician. So what we'd actually done that was unique for this particular one is that we invited the pediatricians from different facilities, something akin to public and private participation. Our patient is patient X or patient 0 for us, because this is the first patient. The patient came because of infection. At the time we were seeing the patient was day 15 of life, had been delivered in a peripheral facility, had gone home and then had complicated. A couple of tests had been done. We initiated support for the baby, and the need was there, and we all agreed as a team that there was need for us to dialyze the patient so as to be able to support the baby. So today, as early as 10 o'clock in the morning, the patient went to theatre. We had a successful surgery where the PD catheter was inserted by Dr. C.S. Otieno, who is our pediatric surgeon in the facility, of course with a couple of other people who are supporting. So the baby has been brought back to the high dependence unit in our Obama ward, where the dialysis has already been initiated. So we've done a couple of what we call flashes and a couple of rounds, and so far so good. We want to thank God because we've been able to get good results with that. Baby still remains very critical in terms of it takes a process, it takes a while before the kidneys open up, and of course we have a couple of complications that we anticipate, but remains critical. We are hoping that he will be able to weather the storm, because at times it can become turbulent, especially at the onset when the dialysis usually starts. If that happens, we pray in the next 48 hours with the repeated test and the support that will come out of these procedures successfully. Otherwise, we want to thank everybody that has been involved, because this has not been an individual's job. Basically, this has been a whole team that has worked day and night. A couple of team members have not even slept just to make sure that this comes to fruition, and we hope that going forward, this is going to be something that is going to be very available, not only for the facility, but also for the other facilities in the environment, so that we are able to support the newborn children and other pediatric children in the spirit of ensuring that every mother, every child, everywhere gets access and gets quality of care.
If the mother is breastfeeding, she needs to watch out that there is actual breast milk for the child, and monitoring how much the urine output is. For example, if she's using diapers, we want to know in 24 hours period how many diapers did she get that are actually having urine. We find mothers who actually think it's a good thing to have two diapers with urine, because they would think their child is saving the money from the diapers, but that's a danger alert. So we want 6 to 8 diapers that have urine in 24 hours. So if the mother sees less, she should get to a hospital facility immediately, because that equates to breastfeeding. And the other thing that needs to be done is hygiene. Hygiene prevents infections. Hygiene from everyone, from the caregiver, from the mother herself, to the baby, and taking care of the other children who will get in touch with this newborn.
We are working towards working out, providing solution for 3 Ds. Number one, delay in terms of decision making at home. For example, if the parents had to delay in terms of making decision to bring this patient to Jaramogi, then we could have lost this particular neonate even before reaching Jaramogi. So it is very important to communicate to the families that once they see the symptoms and signs that Dr. Sharon has talked about, please make quick decision to ensure that you bring the child to the hospital. Delay in terms of the referral system. We want to encourage quite a number of facilities to make decisions to refer very fast, so that if you refer the patient to Jaramogi, we have an opportunity to save that particular life, because that is why we are here. The last D is on the delay in terms of decision making at the referral facility. So our doctors had to make a decision very fast on what to do, whether to refer, whether not to refer. Then they say that if we refer this patient to Kenyatta, then we may lose this patient along the way. And that's why the procedure of putting the catheter was successful. They have to do a lot of consultation. So if we can work as a nation, as a community, in terms of addressing these 3 Ds as far as challenges are concerned, I think we'll be able to reduce maternal and neonatal deaths. The target is that we should be having 70 mortalities out of 100, actually 100,000 deliveries. So this is something that I know it is attainable, it is achievable, and as Jaramogi Oginga Odinga Teaching and Referral Hospital, I want to assure the community in the Western region that we are going to take lead in terms of addressing such challenges and set the pace.